Okay, so good day. The topic assigned to us is pharmacoeconomics as applied to various pharmacy settings, pharmacies in real-world setting applications, and impact of health technology assessment or HTA in governance setting. So we are the group one. Objective, applying HTA integrated pharmacoeconomics in real-world pharmacy settings. For the topic outline, we will just have a quick overview regarding what is HTA, what is pharmacoeconomics, and we will start our report on how can HTA meet the needs of the health system and government decision makers. HTA integrated pharmacoeconomics in governance setting. So we will have a overview on the different strategies devised by the different countries on how to keep the cost of drugs low and how they apply pharmacoeconomics in their government setting. Next is pharmacies in real-world setting applications and impact of HTA. Next is expanding the role of pharmacists in pharmacoeconomics. So why do we need to expand our roles? And how to expand pharmacy roles to include pharmacoeconomics and strategies to initiate pharmacoeconomics into pharmacy practice. To start on, we have what is health technology assessment. So it is defined under RA 11223 or the Universal Healthcare Act as a systematic evaluation of properties, effects, or impacts of health-related technologies, devices, medicines, vaccines, procedures, and all other health-related systems developed. This is to solve the health problem and, of course, improve the quality of life and health outcomes utilizing a multidisciplinary process to evaluate the clinical, economic, organizational, social, and ethical issues of health intervention or health technology. Regarding your UHC or your Universal Healthcare Act, it mandates the institutionalization of HTA as a fair and transparent priority setting mechanism that shall be recommendatory to DOH and PhilHealth for the development of policies, programs, and regulations. Next, what is pharmacoeconomics? Pharmacoeconomics can be defined as the branch of economics that uses cost-benefit, cost-effectiveness, cost minimization, cost of illness, cost-utility analysis to compare pharmaceutical products and treatment strategies. Those I mentioned, excuse me, those I mentioned above, the cost-benefit, cost-effectiveness, cost minimization, and others, those are the types of economic evaluation under your pharmacoeconomics. Next, it helps in forming an economic relationship which combines the drug research, its production and distribution, storage, pricing, and further use by the people. It also helps in decision making when evaluating the affordability and access to right medication to the right patient at the right time, or the rational use of medicine when comparing two drugs in the same therapeutic class of drugs. So the proper application of your pharmacoeconomics will allow the pharmacy practitioners and administrators to make better and more informed decisions regarding products, services they provide. So for more further understanding regarding your HTA and pharmacoeconomics, I have a video here to watch and let's all listen.
Today we'll explain health technology assessment and pharmacoeconomics. HTA is a multidisciplinary discipline aimed at assessing several aspects related to health technology. For example, epidemiological aspects, characteristics of the technology under analysis, safety, clinical effectiveness, pharmacoeconomics, ethical, organizational, social, and legal aspects. Now, let's consider pharmacoeconomics. It's a scientific field that aims at assessing the overall value of a given technology and provides crucial information for a more efficient allocation of healthcare resources. Through pharmacoeconomics, it is possible to identify, measure, highlight, and compare both costs and effects of two or more technologies. Before conducting an economic evaluation, it is important to define different elements, such as the objective of the analysis, the types of alternative technologies available, the time horizon, the population involved in the analysis, the setting of analysis. The starting point for carrying out an economic assessment is the identification and measurement of costs. Direct costs are divided into two categories: direct medical costs and non-medical costs. Direct medical costs are directly related to the disease under assessment and are borne by the National Healthcare Service for prevention, diagnosis, and treatment. On the other hand, direct non-medical costs refer to healthcare intervention and usually refer to travel costs to physicians or healthcare facilities. Indirect costs refer to costs borne by society expressed in terms of productivity loss due to the health condition or related mortality. Finally, intangible costs are difficult to be quantified in monetary terms, as they are related to pain and suffering associated with the psychological consequences of the health condition. Two other crucial aspects are the time horizon and the perspective of the analysis. The latter could be represented, for example, by the perspective of a hospital, of a third-party payer, which in Italy is represented by the National Healthcare Service, or of the society. Essentially, in pharmacoeconomics, there are four main types of economic evaluations. Each technique depends on the way in which health benefits are considered in the analysis. Cost of illness analysis identifies, measures, and quantifies only disease-related costs, but doesn't include the related effects. Cost effectiveness analysis compares different technologies by considering not only their costs, but also their effectiveness, which is expressed in terms of physical, one-dimensional units. This kind of analysis is commonly used and usually more required during price negotiations within regulatory agencies. A specific type of cost-effectiveness analysis is cost minimization analysis that compares alternatives which show the same effectiveness and consists in choosing the cheapest option. Cost utility analysis, instead, compares different technologies by considering both costs and effectiveness, the latter expressed in terms of quality-adjusted life years, QALYs. Finally, there is the cost-benefits analysis that consists in assessing both costs and effectiveness of each alternative in monetary terms. Because it is difficult to quantify health benefits in monetary terms, such technique is not commonly used in the healthcare sector. Economic evaluation results are expressed in terms of ICER. This ratio represents the incremental cost of each incremental unit of effectiveness, coming from the comparison of two alternative technologies. There are two further aspects to consider: the cost-effectiveness threshold and the level of uncertainty. The cost-effectiveness threshold represents the value that a third-party payer is willing to pay for an additional QALY. In fact, each country should establish its own threshold in order to define whether a certain technology is considered cost-effective or not. In Italy, there is not an official defined threshold, but there is a threshold per QALY, which was defined by the Italian Healthcare Economists Association and ranges between 25,000 and 40,000 euros per QALY. In order to assess the robustness of base case results, it is necessary to perform a sensitivity analysis that is a technique aimed at analyzing uncertainty. However, pharmacoeconomics is not enough to provide a comprehensive assessment of healthcare technologies. It is therefore necessary to carry out multidisciplinary and integrated HTA assessments in order to provide a final technology appraisal. That's why HTA is fundamental, as it is able to bridge different competencies: clinical, epidemiological, ethical, and levels of decision-making, from political to managerial and clinical.
Okay, so hope that everything is clear regarding the HTA, pharmacoeconomics, and the different types of pharmacoeconomic evaluations such as your CTA and COA, like that.
So now let's talk about on how can HTA meet the needs of the health system and the government decision makers. Health Technology Assessment or HTA is used in many health systems as a tool to support systematic and transparent decision making whilst allowing for the specifics of the national or local context. HTA is usually thought of as applying to individual drugs or healthcare interventions, for example, surgical procedures or devices, and sometimes clinical pathways or guidelines. Yet, the potential uses of the HTA are much broader than this. HTA could also be used in decision making relating to macro-organizational issues and micro-organizational issues. When we say macro-organizational issues, it includes the architecture of service delivery, choice of reimbursement, mechanism, and the workforce mix. And when we talk about the micro-organizational issues, it relates to individual technologies and their combinations in clinical guidelines and pathways. HTA can be used at different levels of organization by centrally and locally. When we say central, it includes the government and or national HTA agencies. And when we say local, it includes the regional or hospital level budget holders and or local HTA agencies. HTA could also be used to aid decision making in number one, decisions in government on system priorities on what the publicly funded health system should provide in terms of universal care or basic package or scope of the system and the architecture of the delivery of healthcare. HTA could also be used to aid decisions in the following government and or the health system on number one, system priorities. Example, tackling communicable diseases, diabetes, etc. And on the choice of the specific programs of care or package of interventions. It includes evidence-based treatment guidelines. Number two, the prioritization and the use of other single non-pharmaceutical interventions or technologies such as devices, surgery, public health, and so on. And last, the prioritization and use of pharmaceuticals within existing budgets. Example is decisions on reimbursement or pricing, including the restrictions to particular patients, groups, or settings. HTA could also be used to aid decisions at the local level of budget holders. Example, region or hospital level, to help them decide which treatments to make available to their patients. In summary, HTA could be used to inform a variety of different types of decisions, although most commonly it is used for decision making around individual technologies or bundles of technologies. And in making those decisions, the quality of the evidence used in the HTA is very important. It is very vital. Where possible, evidence should be identified through systematic searches and sources should be well documented. The purpose of an evidence-based decision-making process is to provide a guide to systematic and transparent decision-making. So, economic assessment of pharmaceuticals or pharmacoeconomic assessment is a subdiscipline of HTA and describes the formal process of comparing the value of one pharmaceutical with another. The procedure for assessing quality, efficacy, and safety have largely been standardized across developed countries. However, the application of the HTA and subsequent decisions about pricing and reimbursement of medicines remains the realm of national policy makers, and there is considerable variability across countries. HTA can provide an indication of which intervention or bundle or system or health system structure is safer, or more clinically effective, costly, cost effective, or socially or politically desirable than another interventions.
Next is the HTA integrated pharmacoeconomics in government setting. And as we all know, healthcare is a growing concern for governments, and not only for them, but also for the healthcare providers around the world. And these countries have employed a variety of approaches or strategies in an effort to keep pace with the latest health technologies while maintaining the affordable access to healthcare for their patients. So we will have a quick overview on these strategies devised by the different countries such as your UK, Canada, and also here in the Philippines. We have this following approach: pharmaceutical price regulation scheme, or your PPRS, adoption of national formularies forcing pharmaceutical companies to charge less approach, and we have the PhilHealth, or the Philippine Health Insurance Corporation, adaptation of HTA here in the Philippines.
Regulation scheme. This is a system used by the United Kingdom Department to guarantee that the National Health Service affordable access to high quality branded drugs. All branded authorized drugs accessible on the National Health Service are covered by the program. The program's goal is to strike a compromise between costs for the National Health Service and a reasonable profit for the pharmaceutical. If profits exceed a percentage agreed on after negotiations, a company increase prices, delay price increases, or repay the excess Department of Health. Next slide. So the volume for branded medicine pricing and access is a non-contract 12 voluntary agreement the Department of Health and Social Care, or the HSC, and the Association of the British Pharmaceutical Industry, or the ABPI. So this scheme aims to improve patient access to medicine by getting the best value and most effective medicine into use more.
Let's now proceed to the adoption of national formularies in Germany. So their drug regulation and licensing is the German government is responsible for drug regulation and market authorization. The Federal Institute for Pharmaceuticals and Medical Devices regulates all medicines except blood products, sera, and vaccines, which are regulated by the Paul Ehrlich Institute. On the reimbursement levels, prescription for reimbursed medicines, individuals make co-payments of $5.50 to $11 per prescription. Additionally, the Germany as an uses an extensive system of internal reference pricing to set reimbursement limits for groups of medicines that are deemed therapeutically comparable. Um, to add to that, medicines that show added clinical benefit over existing medicines or do not fit within existing therapeutic clusters go through a negotiation process with the National Association of Statutory Health Insurance Funds to determine reimbursement level. Next slide. Um, since manufacturers are initially free to set the market price, the negotiation process determines the price that will take effect 1 year after market launch. If a reimbursement level cannot be agreed upon, the decision is passed to an arbitration body that will set the reimbursement level based on the Federal Joint Committee's appraisal and the prices of comparator medicines. Even a newly patented medicine will be included in the reference price system if the Federal Joint Committee deems that it provides no added benefit over comparators. Now let's proceed to the country of Netherlands. The government of the Netherlands is responsible for drug regulation and licensing. A national agency called the Medicine Evaluation Board assesses and monitors the safety, quality, and efficacy of all licensed medicines. The ZIN, or the Dutch National Healthcare Institute, is the government agency responsible for conducting the health technology assessment of medicines and recommending reimbursement status to the Ministry of Health. The ZIN, or the Dutch National Healthcare Institute, is the government agency responsible for um, conducting the health technology assessment of medicines and recommending reimbursement status to the Ministry of Health. And a committee of external experts, or the Scientific Advisory Committee, provides the ZIN with advice and recommendations on issues of cost and effectiveness, and another external committee, the Insured Package Advisory Committee, provides advice on issues pertaining to social impact. Next slide. So, under the Medicinal Products Prices Act, the Ministry of Health uses external reference pricing to set the maximum allowable wholesale price of a product in the Netherlands at the average list of price of the cheapest available comparable product, branded or generic, in four reference countries like Belgium, Germany, France, and the United Kingdom. Um, Dutch drug prices are broadly controlled by the Medicinal Products Price Act, the preference policy, and voluntary contractual agreements between insurers and suppliers. External reference pricing is applied only when a product is qualified for reimbursement and when a comparable product is marketed in at least half of the reference countries. And note that the Medicinal Products Prices Act applies to both outpatient and inpatient medicines, but not over-the-counter drugs.
Now let's go to the country of Canada. In drug regulation and licensing in Canada, the federal government is responsible for drug regulation and licensing. A federal department called Health Canada evaluates pre-market data on drug safety, efficacy, and quality. Patented medicine are typically priced below the maximum allowable by the Patented Medicine Prices Review Board or PMPRB. This is in part a result of price negotiation by public drug plans in Canada. Private drug plans in Canada do little or no price negotiation after their negotiation of their own, as cost effectiveness is a key determinant of coverage decision. Manufacturers must price at levels that give their product a level of comparative cost effectiveness. Increasingly, public drug plans are using negotiated price discount through the Canadian referred to as product listing agreements to obtain prices that represent value for money and for the government program. Now let's talk about the country Australia. The drug regulation licensing is also run by the government, and the national agency is called Therapeutic Goods Administration. It licenses medical technologies and it is responsible for ensuring their safety, quality, and efficacy. The Pharmaceutical Benefit Advisory Committee, or the PBAC, is a statutory independent expert committee that makes recommendation to the minister regarding which medicine should be covered under the PBS, and any additional condition that should apply. The recommendation may be based on the most frequent diseases or illness experienced by the people in Australia or the citizens in Australia, and this PBS may help them to lessen their expenses in buying their medicine or purchasing their medicine. But there is a condition which should be followed. As a part of its assessment, the feedback evaluates the medicine's cost effectiveness. The feedback is responsible for comparing the effectivity of the drug. For example, the drug A and drug B is both antipyretic drug, but which of them is most effective? And that will be that drug will be recommended by the feedback to the Minister of Health, and the Minister of Health will decide if it is approved in the PBS. In the PBS program or co-payment. And PPAC evaluate medicine cost effectiveness and has the authority to withhold recommendation for positive listing if it believes that the sponsor proposed reimbursement price is too high. The PPAC uses an incremental cost effectiveness ratio defined by the added cost quality adjusted life per year provided by a medicine. On the recommendation of the PPAC, the Minister of Health can define groups of therapeutically similar medicine that will be reimbursed at the price of the cheapest alternative. Again, for example, there are two drug products that is therapeutically the same, but the other one is more expensive and the other one is cheaper, but it has the same effectiveness or effectivity. The cheapest alternative will be the more cheaper but effective drug product. If a particular medicine, a group is priced above the lowest cost alternative, the patient are responsible for paying the price difference in addition to the mandatory PBS co-payment. If you will choose the more expensive drug product, you will shoulder the excess price of it. For example, the drug product A costs 5 pesos and the drug product B costs 10 pesos, and you choose to use the drug product B. The PBS will only shoulder the 5 pesos because it is the cheapest alternative. And the patient or the consumer will shoulder the remaining 5 pesos as it is a mandatory PBS co-payment. In price controls for new medicine not subject to multi-source competition or F1 medicine, it is not part of the therapeutically interchangeable groups. Prices are constrained by the cost-effectiveness consideration of formulary listing. As part of this process, risk-sharing agreements involving rebates paid directly to the government by the company are increasingly used to ensure cost-effectiveness of medicine at least prices and as used in clinical practices.
forcing pharmaceutical companies to charge less approach in country Italy. So in the Italy, universal coverage is provided through Italy's National Health Service or tinatawag na Servizio Sanitario Nazionale or SSN, which established through legislation in 1978. Italy's National Health Service automatically covers all citizens and legal foreign residents. It is funded by corporate and value-added tax revenues collected by the central government and distributed to the regional governments, which are responsible for delivering care. So in this Italy's National Health Services or Servizio Sanitario Nazionale, the residents in Italy receives mostly free primary care, inpatient care, and health screening. Patients make co-payments for specialty visits and procedures and some outpatient drugs. There are no deductibles for residents, and private health insurance has a limited role in Italy's health coverage system. Next slide. Roles of government. So in Italy, the organization and delivery of health services is decentralized. There's 19 regions and two autonomous provinces in Italy, which are responsible for delivering care through 100 local health units. And in that 100 local health units, they are responsible for delivering primary care, hospital care, outpatient specialist care, public health care, and health service related to social care. In Italy's constitution, national health policies and priorities are a responsibility of the central government. The central government also determines annual SSN, Servizio Sanitario Nazionale funding, and controls the allocation of resources to each region. Health agencies and ministries include the following: Ministry of Health, National Committee for Medical Devices, Agency for Regional Health Services, and National Pharmaceutical Agencies. In Ministry of Health, they are the one who oversees healthcare planning, such as determining the essential benefit package, health system ethics, the supply of health professionals, information system, and other areas. National Committee for Medical Devices, they are the one who develops cost-benefit analysis, and they determines reference prices for medical devices. Agency for Regional Health Services are the sole institution responsible for conducting comparative effectiveness analysis, which is accountable to the regions and to the Ministry of Health. Lastly is the National Pharmaceutical Agency, which governs prescription drug pricing, reimbursement policies, and all other matters related to the pharmaceutical industry. Next.
The central government defines as national statutory benefits package offered to all residents in every region, and this includes prescription drugs. In order to meet cost containment objectives, the central government can expose recovery plans on regions with healthcare expenditure deficits. These plans identify the tools and measures needed to achieve economic balance. Next slide. Reference prices for medical devices and pharmaceuticals are set according to cost effectiveness studies carried out by the National Committee for Medical Devices and the National Drugs Agency. Prices for reimbursable drugs are set to negotiation between government and the manufacturer using criteria such as comparative cost effectiveness prices for non-reimbursable drugs and are set by the market. Next slide. Japan's statutory health insurance systems, or HHIS, provides universal coverage. It is funded primarily by the taxes individual enrolled in either an employment-based or residence-based health insurance plan is required. The national government sets the fee scale. Japan's prefecture, prefectures develop regional delivery system.
Next is the roles of government in Japan. The national and local government required by law. Uh, the national and local government are required by law to ensure a system that efficiently provides good quality medical care. The national government regulates nearly all aspects of the statutory health insurance system. The national government also sets the SHIS fee schedule and gives subsidies to local governments. The municipalities and prefectures of Japan, insurers and providers. It also establishes and enforces legal regulations for insurers and providers. Government agencies involved in healthcare include the following: uh, Ministry of Health, Labor and Welfare, Social Security Council, Central Social Insurance, Medical Council, and Pharmaceutical and Medical Devices Agency. The Ministry of Health, Labor and Welfare drafts policies, documents, and makes detailed regulations and rules once general policies are authorized. Under this Ministry of Health, Labor and Welfare is the Pharmaceutical and Food Safety Bureau, the Pharmaceutical Regulatory. This is where the decisions of for application approval is made. And also, the Organization for Pharmaceutical Safety and Research, also known as PICO or the DO, or the Drug Organization, is an independent body that is in charge of discussing drug development programs with industry. Next is for pharmacy services. The Central Health Insurance Medical Council revises provider service fees on an item-by-item basis to meet overall spending targets set by the cabinet. Highly profitable categories usually see larger reductions. Next is the price revisions for pharmaceuticals are determined based on market survey of actual recurrent prices, which are usually less than the listed prices. Drug prices can be revised downward for new drugs selling in greater volume than expected and for brand name drugs when generic equivalents hit the market. We all know that the Japan is has high economy, so they can set the prices lower than the usual. So next.
Next is the Philippine Health Insurance Corporation, or the PhilHealth. PhilHealth is a government-owned and controlled corporation attached to the Department of Health, and they administers the national health insurance to the Filipino citizens. PhilHealth has its HTA committee. The HTA Committee of PhilHealth was established March 1999 to develop reimbursement policies on medical claims based on the cost based on the cost effectiveness of tests and treatments. Also, they are authorized to arbitrate appeals and questions on the effectiveness of drugs that were introduced in the Philippine market but were not listed in the PNDF, or Philippine National Drug Formulary. So there are three major programs of the HTA. First is the conduct of drug assessments to determine which drug should and should not be reimbursed by PhilHealth. Drugs assessed to be effective, safe, and cost-effective are temporarily included in PhilHealth Positive List. So what is this PhilHealth Positive List? Positive List is consists of drugs that PhilHealth reimburses but are not yet included in the current edition of the PNDF. And apart from drugs, the HTA committee also evaluates the safety and effectiveness of medical devices and surgical procedures. Next is the appraisal and dissemination of clinical practice guidelines, or the CPGs. Specific recommendations of disease assessment, laboratory tests, drug treatments, and admission policies are extracted from the screened CPGs and assessed for applicability, and they assess it for its applicability to local settings. Next is the evaluation of effectiveness and safety of medical and surgical procedures. One of the goals of the committee is to support providers' effort in adhering to the law that accredited providers are required to use only effective and appropriate medical and surgical interventions. Next is the strategic directions on access to medicines for Filipinos. Pharmaceuticals represent the largest single item of healthcare expenditure, currently at about 42% of family expenditure for medical care. They also form the second largest component of government expenditure in terms of payments made through the National Health Insurance Program, at about one-third of all reimbursement made by the PhilHealth in 2010. And in 2010, the total pharmaceutical market in the Philippines was reported to be about 124 billion, where 11 to 12 billion, or 10% of the entire market, comes from the government spending. Included in this spending for pharmaceuticals are imports, PhilHealth reimbursement, drug procurement of DOH and other national agencies, and LGUs. In 2006, a drug price survey by the World Health Organization and the Health Action International revealed that Filipinos are among those who pay the highest drug prices in Asia, with innovator brands costing 16 times more and generic drugs costing 15 times more when compared with international reference prices. Thus, the Philippine government embarked on a mission to improve access to medicines by reducing the prices of medicines commonly bought by the poor. So we have this SAR access framework, which encompasses the five major pillars of the Philippine medicines policy. And this PMP is an instrument of commitment for ensuring access to essential medicines of assured safety and quality for all. For the first pillar, we have the safety, efficacy, and quality. This component shall ensure the manufacturing, packaging, procurement, the import, export, distribution, supply, and the sale of drugs, product promotion and advertising, and including the clinical trials. They should be carried out according to specified standards of safety, efficacy, and quality. So the next pillar is the affordability and availability. For this pillar, the government shall employ in a collaborative endeavor with all partners and sectors to ensure that Filipinos have adequate and timely access to medicines at all points of health service delivery. And the government shall also exercise its power to influence the local supply and demand of medicines through strategies as well as the transparent and rational pricing to assure that medicines are affordable to the individuals, families, and communities. Next is adaptation and use of generics shall be actively promoted in both the public and private sectors as government commits to increase financing for medicine and deliver the best health outcomes to more patients. Next is the rational use of medicine. The DOH, in collaboration with health providers as well as patients and consumers, shall promote the rational and cost-effective use of medicines to achieve the best treatment outcomes for patients while generating efficiency and cost savings in the healthcare system. So the basis for this is the Philippine National Drug Formulary, the current edition, for the selection and procurement of medicines in all public health facilities. Also, the PNF shall govern the reimbursement of drugs by the PhilHealth in both public and private health facilities. Under this pillar also, the patient and consumers shall be educated and informed on the quality, safety, and proper use of medicines, as well as their right to demand low-cost medicines through generic substitution. And for the fourth and fifth pillar, we have the accountability, transparency, and good governance. And for the fifth pillar, we have the health system support, which is this pillar cuts across all the other components of the PMP, with the government exercising its prime responsibility as key enabler.
The role of HTA in low and middle income countries, for example, is the Philippines, based on the type of economic evaluation. A consistent theme throughout the literature is an information on cost effectiveness, and HTA more generally has an important and influential role in reimbursement decision making. The success of applying the cost effectiveness approach in Asia will be dependent on two major factors. First will be the technical competence of the end users and the transparency of the decision-making process. The role of cost-effectiveness analysis in pharmaceutical reimbursement is growing, but there is a need for a greater cooperation between the stakeholders or regulators and payers to improve the pharmaceutical evaluation process in the interest of the patient. Growth in the use of HTA in pharmacoeconomic studies is often explained as being due to the need of effective measure to control health spending and gain efficiency or best value for money within a health budget. As we belong to these low and middle income countries, if we like to improve or or if we would like that government will improve their actions about the health spending or the health expenditure that we Filipino citizen experiencing, we also need to cooperate to the government for them to assess what are the things that is needed to improve, and the evaluation process will be done through our answers, and the communication between the government or the regulators and the payers or the patient will result to the less health expenditure, and we will also gain the maximum efficiency for the price that we pay for our own health.
Pharmacies in real-world setting applications and impact of HTA. Number 1. Healthcare costs. Pharmacists have a major role in lowering costs by critically reviewing the pharmacotherapy of multimorbid elderly patients. The reduction of inappropriate prescribed medicines not only reduces savings in the cost of each individual medicine, but also reduces the risk of adverse drug events that often contributes to prolonged and expensive hospital admissions. Number 2, pharmacists Number 2, pharmacoeconomics, cost savings, and cost avoidance. In pharmacoeconomics, pharmacists can have a major influence on healthcare decision makers with regards to better allocation of resources and expenditures, so as to optimize the population's health from the use of medicines. Cost savings can be applied by changing the patient's expenses. Example, switching from intravenous to oral therapy where appropriate. Cost avoidance refers to an intervention that reduces potential future spending that may occurred without the intervention. As an example of this discontinuation of potential inappropriate medication of patients, reducing the potential admission to the hospital avoidance actual cost of medicine. Number three, medication errors. Medication errors are very costly to healthcare system, but a large portion of these are preventable. Pharmacists have demonstrated a positive effects in preventing medication errors and limiting inappropriate prescribing, thus reducing healthcare costs by preventing hospital admissions or reducing hospital length of stay. Number four, prevention and management of disease. Community pharmacists are ideally placed to undertake health screening for disease prevention and progression, and to aid in the diagnosis of new disease. Example, type 2 diabetes. Pharmacy-based health checks have been shown to be cost-effective when actively screened at risk patients. The delivery of point to the delivery of point care testing in community pharmacies may be used not only for screening purposes but also in the management of chronic disease. This shows that pharmacists helps lessen the expenditures of the patients with the use of pharmacoeconomics.
Okay, next is expanding the role of pharmacists in pharmacoeconomics. So, bakit nga ba kailangan nating i-include sa role natin as a pharmacist ang pharmacoeconomics? So, first, determination of the value of pharmaceutical products and services. As we all know, there are diminishing resources regarding our pharmaceutical products and services. That's why many pharmacies are being challenged to provide quality patient care at minimal cost. So in order for us to do this, we have this pharmacoeconomics, which provides pharmacists with a new opportunity. This is the ability to quantify the value of the products and services they supply. And also, it provides the means to place a value on these goods and services. When we provide value on these goods and services, it can help to balance the cost with patient outcome and choose between competing treatment options and assist in medication use decisions. Next is balancing cost and quality of care. Using pharmacoeconomic techniques, it enables the pharmacist to balance cost and patient outcome to determine which treatment alternatives yield the best outcome per money the patient spent. And pharmacoeconomic analysis also can assist in determining which products and services represent the best value for patients, department, and institutions. Next is for the third one, increase pharmacists' involvement in drug decision-making process. Increasing the number of pharmacists are becoming involved in institutional medication use decisions. And for them, ang nagiging katumbas nito when they involve in institutional medication use decisions is they're already assessing the costs and consequences of various alternatives and, recommending the most cost-effective treatment options to medical decision makers. So parang ang nagiging katumbas nun is they are already including pharmacoeconomics as their role. And in order for them to do this, they use pharmacoeconomic analysis to support and justify many of their recommendations and decisions. So medication use decisions that can benefit from pharmacoeconomics includes the formulary management, drug use policy, resource allocation, and individual patient treatment decisions. So our main goal is to provide sound drug therapy that should contain three components. We have your safety, efficacy, and of course, pharmacoeconomic value of services and treatment options that we will um, we will use. Next is the what are the misconceptions regarding pharmacoeconomics. So first, pharmacoeconomics equals cost effectiveness. Of course, that is misconception kasi when we talk about cost effectiveness, it is only one of several methods used to place value on drug therapy, whereas your pharmacoeconomics is a broad assessment or broad type like that. Since one of the types of economic evaluation that used in pharmacoeconomics is your CEA or your cost effectiveness analysis, cost minimization, cost benefit, cost utility, and using those economic evaluation, we are already assessing the patient's quality of life, preferences, and satisfaction. So, never silang magiging equal. Cost effectiveness ay parang method lang to have a pharmaceut pharmaceut pharmacoeconomic assessment. Pharmacoeconomic assessment. Next is the pharmacoeconomics does not affect pharmacy practitioners. So, kanina kaka-define lang natin kung bakit kailangan nating i-include ang pharmacoeconomics sa role natin. So, of course, this is misconception kaya kailangan natin bigyan ng reason. So, the pharmacy is often referred to as drug expert, not drug dealer nor drug seller. Okay, so kidding aside. They are an ideal healthcare professional to assess the costs and consequences of drug therapy. So the potential role of pharmacists in pharmacoeconomics is significant as all pharmacists can benefit from using performing pharmacoeconomic research. And next is pharmacoeconomic is a fad. So meaning parang pharmacoeconomics is just a short-term goal or short-term activity na popular siya ngayon, and at the long run is nag-fade siya. The healthcare environment becomes increasingly cost-conscious, so pharmacoeconomics will play a lasting role in pharmacy practice kahit na we already stabilized, the government stabilized allocating, they have already allocated big budget in health. We can pharmacoeconomics is still a need. Next is pharmacoeconomics equals cost containment. So sa misconception na to, this provides that when we use pharmacoeconomics, we are just focusing on lowering the price of this, lowering the price of the services, pero we are not including the patient outcome. Actually, by applying pharmacoeconomic tools like your cost-effective analysis, patient outcome and economic outcomes are both considered. Next is pharmacoeconomics is a compromise of clinical responsibility. Incorporating economics into clinical decision does not necessitate a compromise in quality of healthcare delivered. Through utilization of appropriate pharmacoeconomic principles and methods, cost is balanced with quality to determine which treatment alternatives yield the highest quality per money spent. Balancing cost and quality of care can assist pharmacists in maintaining high-quality patient care at a potential cost saving to his or her institution and patients. So those are just misconceptions regarding our pharmacoeconomics, but actually we need to include pharmacoeconomics in our roles since we are the drug expert.
How to expand pharmacy roles to include pharmacoeconomics. First, we have academic programs. All pharmacy students need exposure to pharmacoeconomics and its potential impact on their future practice of pharmacy. Both graduate and undergraduate trained pharmacists can benefit from acquiring pharmacoeconomic skills. Students awarded undergraduate pharmacy degrees may be pressured to incorporate pharmacoeconomics into their practice regardless of the settings. Second, we have fellowship and residency training concentrated in US. US residency programs aim at training pharmacists to apply pharmacoeconomics in hospital settings have recently been developed. The two programs developed to date include programs at the Brigham and Women Hospital and New England Medical Center, and both in Boston and Massachusetts. Third, we have published educational materials. Prints, textbooks, and journal focus on pharmacoeconomics can provide a basic introduction to the principle and methods of pharmacoeconomics. However, these materials should be combined with practical experience or formalized training. And lastly, we have continuing education programs. These programs can be helpful in learning the basic principles and methods of pharmacoeconomics and how to apply pharmacoeconomics to various healthcare settings. However, it is important to note that most of these programs provide a thorough introduction to the basic of pharmacoeconomics, but again should be combined with practical application following published guidelines. Strategies to initiate pharmacoeconomics into pharmacy practice. First, we have strategies for the practitioners. Whereas using pharmacoeconomics literature is a vast and powerful source of information for pharmacists and others who must make decisions about services and products, and followed by conducting pharmacoeconomic research. It identifies, measures, and compares the costs and consequences of pharmaceutical products and services. Then approach to performing pharmacoeconomic research adapted from Jolicoeur et al. 1992. First, define the pharmacoeconomics problem. Second, determine the study's perspective. Third, determine the treatment alternatives and outcomes. Fourth, select the appropriate pharmacoeconomic method. Fifth, place monetary values on the outcome. Six, identify resources. Seven, establish the probabilities of the outcome events. Eighth, use decision analysis. Ninth, discount costs or perform a sensitivity or incremental cost analysis. And 10th, present the results. As for our second strategies, we have strategies for administrator. First, creating an awareness of costs. Recognizing cost as an important part of today's practice is critical. Cost is no longer an unacceptable topic for discussion in healthcare institutions. Furthermore, concerns with cost need to be part of everyone's job. It is important to realize that including cost in healthcare decisions does not have to have a negative influence on the quality of care. Second, we have incorporating pharmacoeconomics into the departmental mission. Incorporating pharmacoeconomics into the mission of the department can emphasize the important role that pharmacoeconomics plays, including pharmacoeconomic assessment of high-cost medication in the annual department goals and objectives, and incorporating pharmacoeconomic responsibilities into listing job prescription will illustrate the department's commitment to this discipline. In some institutions, it may become necessary to devote a positions or division of pharmacoeconomics in the department. And third, mandating pharmacoeconomic data from pharmaceutical companies. Data generated by the pharmaceutical industry does not necessitate bias in result reported. By using and applying the guidelines for assessing the soundness of the economic evaluation, the worth of the study can be determined and the result used appropriately. Also, it should be remembered that the study perspective, treatment, alternatives, compared and outcome under study may not be relevant for the specific institutions. And lastly, we have using cost containment to provide pharmacoeconomics Although cost containment strategies are not synonymous with pharmacoeconomics, they can provide a stimulus to incorporate pharmacoeconomics into a pharmacy department. For example, providing drug acquisition costs in pocket formularies distributed to healthcare professionals, example, physicians and nurses, may decrease total medication costs for particular agents. These efforts may not be pharmacoeconomics ally sound in that they do not consider both economic and patient outcomes, but when used appropriately, they can make measurable decreases in institutional costs.
In conclusion, pharmacoeconomic analysis is important since payers such as third-party payers or government-private health plans utilize them when determining whether to reimburse a claim. This results in decreased adherence, lack of prescription filing, decreased physician visits, and increased emergency room care. Healthcare practitioners, such as pharmacists, can benefit from applying the principles and methods of pharmacoeconomics to their daily practice setting by putting pharmacoeconomic principles, methods, and theories into practice to quantify the value of pharmacy products and pharmaceutical care services used in real-world settings. This is our references. And thank you for listening.